Our first presenter is Anya Thakur, and she came to us from Boston University with a BA in economics and a BS in human physiology. The title of her presentation is Understanding and Addressing Postpartum Depression in the United States. So Anya, you are on.
Hi, thank you. Let me share my screen. Okay, can you guys all see that?
Yep.
Yes.
Okay. All right. So hello, everyone. Thank you for the introduction. My name is Anya, and today I'm going to be presenting about postpartum depression in the United States. In this presentation, I'm going to define and describe the magnitude of the problem, describe the causes, and give an overview of the current policy approaches, and finally offer specific recommendations. First, I'll define postpartum depression and the screening tool of interest for the rest of the presentation. Postpartum depression, or PPD, is a highly stigmatized mental disorder that affects mothers in the perinatal period and can negatively affect their infants and families. Approximately 20% of mothers that deliver per year experience postpartum depression. Okay. Screening for postpartum depression is usually done through the Edinburgh Postpartum Depression Screening, or EPDS, which was developed in 1987 and has since been widely used for screening in many countries. It consists of 10 questions and is a self-reported measure that relies on the mother's own reporting of her symptoms. So going into the statement and the magnitude of the problem, postpartum depression is a serious and prevalent mental health condition among new mothers in the US. As I mentioned before, about 20% of mothers that deliver per year experience PPD, and the condition is often overlooked, undiagnosed, and untreated due to a lack of awareness, stigma, and inadequate resources, all of which can have long-lasting and severe consequences for both the mother and the child, as well as the family. Estimates suggest that a significant number of PPD remains undiagnosed in the US. A 2019 review found that upwards of 50% of women with PPD go undiagnosed. Additionally, it was found that only about 22% of women screening positive for depression received mental health treatment. Effective interventions and treatments require addressing significant barriers such as the lack of public awareness, limited screening and diagnostic tools, and low priority given to PPD. Marginalized women suffering from PPD face additional barriers to accessing healthcare and support services due to factors such as poverty, discrimination, lack of transportation, and cultural and language barriers. Healthcare coverage and affordability can also have a significant impact on their ability to receive proper treatment, all of which can exacerbate their symptoms and contribute to the economic and social marginalization. State and racial/ethnic level data on PPD prevalence and related indicators can provide valuable insights into the magnitude of the problem and inform policies and interventions that target specific populations. However, data collection and reporting methods may differ across states, and the availability of data may vary. This just highlights the need for comprehensive and standardized surveillance systems. Addressing postpartum depression requires a comprehensive and coordinated approach that involves healthcare professionals, researchers, policymakers, advocates, and community members. Policies and practices that prioritize maternal mental health, increase awareness and education, increase and improve access to healthcare and support services, and reduce stigma and discrimination can help reduce the burden of PPD and improve the well-being of mothers, children, and families. Going into the biological background and the disparities in access, during pregnancy, childbirth, and lactation, a woman's body undergoes physiological and hormonal changes, all of which can affect the hypothalamic pituitary adrenal, or HPA axis. The HPA axis regulates the stress response. Cortisol is a hormone produced by the adrenal gland and is one of those hormones that is regulated by the HPA axis. High cortisol levels have been studied as a potential biomarker for PPD. There is also placental corticotropin releasing hormone, which is another hormone produced during pregnancy and increases the risk of PPD. The oxytocin signaling network is vital for bonding between mothers and infants, and lower oxytocin levels are associated with an increased risk of PPD. Blood levels related to allo have also been studied as another potential biomarker for the condition. Disparities in access to maternal mental health services can significantly impact outcome for mothers with PPD. Women who are low income, uninsured, underinsured, or from marginalized communities may face barriers in accessing mental health care, such as a lack of available services, transportation challenges, or the stigma surrounding mental health issues. These women may not receive timely and appropriate screening and treatment for PPD, which can lead to more severe symptoms and poorer outcomes for both the mother and the child. Women from marginalized communities are at a higher risk for PPD and are less likely to receive treatment. Now, looking at the policies currently in place in the United States to address the problem, postpartum depression policies and guidelines can vary from state to state in the United States. Many states have implemented policies aimed at improving the screening, diagnosing, and treatment of PPD, while also increasing the awareness. However, only 13 states, all of which that are highlighted in red in the map, are the only states that have mandated PPD screening for new mothers. In this presentation, we'll be following Massachusetts specifically, and this is because Massachusetts was ranked as a top state in the US for maternal mental health in 2021. This is based on the presence of legislation and policies addressing maternal mental health, access to mental health treatment for pregnant and postpartum women, and the availability of support and resources for mothers experiencing perinatal mood and anxiety disorders such as PPD. Massachusetts has specific legislation in place requiring healthcare providers to screen all new mothers for PPD at least once during the postpartum period, and mandates that healthcare providers provide information and resources to mothers about PPD and treatment options. In 2010, Massachusetts enacted an act relative to postpartum depression. This is established to promote the health and well-being of birth parents, children, and families. The law requires data reporting by both carriers and providers for routine clinical appointments in which medical services are provided to a person who has given birth within the previous 6 months. The primary components of this legislation are 1, establishing a postpartum depression legislative commission, and 2, requiring that the Massachusetts DPH promotes a culture of awareness, destigmatization, and screening for postpartum depression. This slide and the following include the process maps that I created whilst working with the Massachusetts Department of Public Health. I worked closely with 2 health centers that are considered to be models for administrating EPDS screening and making sure that mothers receive the support that they need. These process maps follow the process of the screening from when the woman finds out she is pregnant up until she is a year or 2 out from delivery. It also includes IT and billing departments as they are involved with making sure that the screening process follows through smoothly. The goal of these process maps is to make sure that other health centers can evaluate their own screening processes and mend any gaps that they may have. In creating these process maps, I learned a few key lessons that I think are critical for other health centers and even other states to learn from. First, these process maps provide a structured and systematic approach to perinatal depression screening and care delivery. There is a clear division of roles and responsibilities among the OBGYN team members, and this ensures efficient and coordinated care delivery. The use of electronic records such as EMRs and EHRs ensures that there is well-documented and accessible patient care information. Billing and reporting of EPDS screenings can be facilitated by the use of electronic records. Follow-up screenings and referrals are emphasized in both process maps to ensure that patients receive necessary care and support. Finally, patient-centered and evidence-based approach to PPD screening and management can lead to improved outcomes for patients and their families. Specific recommendations for other health centers in Massachusetts and across the country include the following. Screening for PPD should be universal and integrated into routine maternal care. Validated screening tools can help healthcare providers identify PPD symptoms more accurately, and the provision of follow-up care is essential in addressing postpartum depression. The key to success is making sure that there is a comprehensive and integrated approach to PPD screening and care. It is also crucial to develop evidence-based and culturally sensitive screening protocols. Moving forward, it is imperative that healthcare providers are trained in using standardized screening tools and establishing clear referral pathways. Providers build trust and rapport through empathy, active listening, and communication skills. We must also ensure that resources are available to support women who require further assessment or treatment for PPD. And we must advocate for policy changes to ensure that women have access to the support that they need, as well as prioritizing the mental health and well-being of new mothers. As we move forward, the hope is to implement these recommendations and improve outcomes for women affected by postpartum depression in other health centers, as well as other states. Thank you so much for your time. I would like to give a special thank you to Mary Catherine, who is my advisor and reader, Beth Buxton from the Massachusetts Department of Public Health, Lynn Community Health Center, and the Family Health Center of Worcester, my family, so my parents, my brother, Gabriella and Ellie, and my friends. At this time, I'll take any questions that you may have.
Yay. Kristen, are there any questions in the chat?
Hold on. Let me see. Sorry. Shoot. Let me see. There's some coming in. Hold on a second. Let me see.
Sorry, I put
Great job. Everything. It says great job, great presentation. Okay. Okay, here's a question. Is there any data about PPD during the COVID-19 pandemic? Were there any notable changes?
Okay, yeah, so there is actually some data that suggests that the COVID-19 pandemic has had an impact on the prevalence of PPD, as well as other perinatal mental health disorders. So some notable changes include an increase in the prevalence of postpartum depression during the pandemic. Some of the numbers that I've seen are usually around 30% compared to the usual average of 22%. This just highlights the impact of stress and social isolation on maternal mental health. There's also new risk factors that have been identified. A lot of it has to do with social isolation and financial stress and just general uncertainty about the future. And there's also been a significant disruption of access to care during the pandemic. It's just been more difficult and for women to receive timely and appropriate treatment for postpartum depression.
Good. Thank you. Okay, we have a second question. They're asking, in your time analyzing MA, did you look at any of the states that aren't doing as well as comparison point? And what was the biggest barrier in those states?
So during my time with the Department of Public Health, we actually focused more on the health centers within the state that aren't doing so well. So I talked with 2 health centers that are doing extremely well, and then 1 health center that was not doing as well. And basically, they talked about how they weren't receiving as much funding from the government as they hoped they would, but also they had a lot of other barriers that they were faced that a lot of the other health centers didn't necessarily have to deal with. They didn't have as many providers as they would have liked, and that was just MDs or DOs. They didn't have as many nurse practitioners. There was also a lot of issues within administration itself, and so that contributed to them falling behind.
Thank you. Also, thank you so much, Anya, for a great presentation. Congrats on finishing your term. But I just had a quick question. You mentioned this briefly, but I was wondering how healthcare professionals, like researchers, policymakers, advocates, community members, how can everyone kind of work together to address the issue of PPD and just improve the overall well-being of mothers and families?
Thanks, Joyce. So healthcare professionals, advocates, and community members can work together to raise awareness, mostly for the signs and symptoms of PPD, as well as educating women and their families about the importance of seeking care. They can also provide information on available resources and support groups. It's important that researchers conduct their studies to better understand the causes and effects of PPD, just to help with evaluating the effectiveness of the interventions. This research can also help inform a lot of policy changes that have to be made, and support services like healthcare professionals and community organizations can also collaborate to provide more support services for women within the community.
Our next presenter is Chelsea Contreras, and she came to us from Brandeis University with a BA in Health Science, Society, and Policy. Title of her presentation is Maternal Health Crisis, Racial and Ethnic Disparities in Severe Maternal Morbidity Across the United States.
Thank you, Mary Catherine, for the introduction, and let me start sharing my screen. And also thank you everyone for being here. Okay, so good afternoon, everyone. So today I'm going to be presenting on the racial and ethnic disparities in severe maternal morbidity. So what is severe maternal morbidity? So according to the American College of Obstetrics and Gynecology, they define severe maternal morbidity, or SSM, as unintended outcomes of the process of labor and delivery, which result in either short or long-term consequences for women's health. And it's also defined as near misses for maternal mortality, which means that if they haven't been caught before or treated, then it could result in maternal death. And also SSM is measured using administrative hospital discharge data, which is based on the CDC's International Classification of Diseases, which lists 21 indicators for SSM. Okay, so these are the list of the 21 indicators for SSM, which include 16 diagnoses and 5 procedures, and the most common indicator being blood transfusions, which we will get into more a little bit later. So a little bit of background. So why is this an issue? So severe maternal morbidity has been increasing over the years, and there has been a 200% increase in the rates of SSM between 1993 and 2014, resulting in a jump from 49.5 cases to 122.3 cases per 10,000 deliveries. And also this affects about 60,000 women in the US every year. And so this graph is from the Commonwealth Fund, and it shows the relationship between SSM and these different factors. And for this paper, I mainly focused on the racial and ethnic disparities. And we can see that the SSM rates are much higher for the racial and ethnic minority as compared to white birthing people. And more notably on this graph, we see Black women as the highest rate for SSM. And they are disproportionately experiencing SSM than any other race or ethnicity here. And this is nothing new because SSM disparities have always existed, but there has been a lot more advocacy work and awareness brought to this in the past couple of years. So the objective of my paper is to review the current research in the US that addresses the racial and ethnic disparities in SSM, and also highlights the current strategies that are being done to reduce this disparity. So for my methods, I use these 3 sources, PubMed, Web of Science, and Professor Shobino had an amazing list of references already on this topic, which she shared with me. So I'm very thankful for that. And of these articles, that I reviewed, the only ones that were included were those that were US-based studies, those that included racial and ethnic disparities as the main variable, and severe maternal morbidity as the main outcome. And those excluded were studies that focused on other disparities within SSM, such as age or insurance or neighborhood location. And also excluded were studies that looked at general morbidity or maternal mortality. So there were a total of 11 studies reviewed, and 9 were retrospective cohort studies and 2 were cross-sectional studies. And the main data sources used were birth certificates that were linked to hospital discharge data, the national inpatient sample, and also the state inpatient sample. And 2 of the studies mainly focused on Black-white differences. 1 study focused on Indigenous and white differences, and the other 8 studies focused on more general racial and ethnic disparities. And the studies also included other variables such as purity, comorbidity, neighborhood location, but those were not the main variables. So for my results section, I broke it up into 3 different parts. The first part that we're going to talk about are the state data. So for the state data, there were 2 New York studies, 2 California studies, 1 Massachusetts, Arkansas, and Washington. And all the studies found that Black women had a higher rate of SSM compared to white women, even after adjusting for the other variables like education, age, parity, and other socioeconomic status factors. And something that was interesting was the Washington study, which looked at the Black-white differences in SSM varied by hospital. So they broke up their data into a couple different sections. They had low, medium, and high percentage of deliveries to Black women. And they found that women who delivered in, specifically Black women who delivered in hospitals that were of higher Black percentage to the Black women deliveries had a higher rate of SSM. But we will also talk more about some of the drawbacks of the study later on in the discussion. Next, we're going to be looking at the multi-state data, and there was only 1 study that observed multi-state, and they used the state inpatient database. And the states included in the study were Arizona, California, Florida, Michigan, New Jersey, New York, and North Carolina. And similar to the state data, they also found that there were racial and ethnic disparities in SSM between Black and American Indian as compared to white women. And lastly were the 3 studies that looked at national data. 1 focused on Indigenous and white populations, and that study found that the incidence of SSM was twice as high for the Indigenous populations as compared to white women, and also the disparities continued when looking at rural and urban settings. Also, another study focused only on the Black-white differences, very similar to the Washington study I just talked about, which broke it up into different hospital types. And they also observed that Black women had twice as high rates of SSM as compared to white women. And finally, the last study examined differences in SSM based on different phases of pregnancy, so during the intrapartum period, antepartum, and postpartum. And they found that Black women had a higher percentage of SSM throughout all those stages, but specifically found the highest disparity during the antepartum period. So now we're going to go into the discussion. So overall, all of the studies showed that Black women had the highest rates of SSM as compared to all other racial and ethnic groups. Hispanic and Asian were disproportionately affected, but at a much lower rate than Black and Indigenous women. Also, going back to the studies that I pointed out that use hospital delivery sites as a measure for SSM, this is not the most effective way of measuring disparities, because a lot of the times SSM, things that affect SSM happen way before a woman or a birthing person enters the hospital. And those are much more important variables to look at. And this is explained by the 3 delay model. Also, all of the studies excluded blood transfusions in their results. And even though in the beginning I said that blood transfusions was the #1 indicator for SSM, the studies chose to exclude that because they use administrative data, and it's hard to distinguish whether it is a severe maternal morbidity case or just a regular morbidity case, because we won't know how much blood units were used during that time. Next are the limitations. So some of the limitations are that most of the studies focus on Black and Hispanic women, and there's not enough data on Asian or other ethnicities and Indigenous women. So I feel like there needs to be more data on that so we can see disparities that exist in those ethnicities as well. And then also, not all studies observed the same variables, which may account for some differences. So for example, the study that looked at the hospital differences did not study the same variables as other studies who looked at maybe neighborhood differences or insurance differences. Next, also, a lot of the studies were retrospective cohort studies, which make it difficult to adjust for all possible variables occurring during that time of delivery. But there is some hope, even though there is a lot of disparities that exist. So there is a lot of advocacy work being done now, and one of the groups are Black Mamas Matter, and they raise awareness to help improve maternal health. Also, another study in California found that the AIMS, which is the Alliance for Innovation for Maternal Health, Hemorrhage Quality Improvement Collaborative, significantly reduced racial disparities, specifically for hemorrhaging during birth for Black women. Also, more recently, last year when the Biden and Harris administration came, they released the White House blueprint for addressing the maternal health crisis, which focuses on many goals to help build a more equitable world of medicine for maternal and child health. And it really focuses on addressing the racial and ethnic disparities in those goals. So that is the end of my presentation. Thank you, everyone, and a special thank you to Professor Donna Strombino, who really helped me through this process and provided amazing edits and references for this. And also thank you to the PopFam department, as well as my friends, peers, and family.
Yay. Thank you, Chelsea. That was great. So our next presenter is Gabrielle Foster. She came to us from Massachusetts College of Pharmacy and Health Sciences with a Master in Public Health, and Ramapo College of New Jersey with a BS in Biology. The title of her presentation is Maternal Stress and In-Utero Autoimmune Disease Programming, Implications for Racial Health Inequities. So, Gabrielle.
Great, thank you so much. So good afternoon, everyone. Thank you, Mary Catherine, for the introduction. I'm Gabrielle Foster, and today I will discuss my scoping review focusing on maternal stress and in-utero and the autoimmune disease programming and the associated implications for racial health inequities. Okay, so before we dive into specifics of my study, let's look at the diagram on the left side of your screen. So this diagram illustrates the causes of autoimmune disease. While true etiology of something is somewhat elusive, we know that these autoimmune diseases rise from a combination of three factors: genetic predisposition, environmental factors, and immune regulation. Childbearing women are particularly vulnerable population regarding autoimmune diseases. They have the highest rates of chronic disease, morbidity, and mortality, higher overall incidence of autoimmune disease, and accumulate the highest amounts of stress over their life course. From an environmental standpoint, risk factors for Black women are even higher as they experience higher rates of poverty, reduced healthcare access, food deserts, and typically live in areas with higher population density, which confers the highest rates of viral infections and pollution exposure. Today, we will explore the concepts of weathering hypothesis, which in essence posits that health inequity experienced by Blacks is in large part a consequence of cumulative physiological deterioration from living in societal conditions where they constantly suffer economic, social, and political exclusion. So I created this conceptual map to guide you through the themes and concepts involved in this study. This section highlighted in the red box is encapsulating the primary objective of this review, which is to analyze the timely research regarding proposed mechanisms of in utero programming of autoimmune diseases from stress accumulation in mothers. This map highlights how maternal stress accumulation is theorized to lead to increased maternal infections and inflammatory processes and hormone dysregulation, which increases maternal and theoretically fetal glucocorticoid levels, namely cortisol, which is a key stress hormone. And elevated fetal glucocorticoid exposures increase the risk of having autoimmune disease later in life. The secondary objective of this review is to explore the role of sociodemographic factors and the Black experience in contributing to Black female stress accumulation via weathering hypothesis. This portion of the diagram framed in the smaller red box shows the influence of sociodemographic factors contributing to increased maternal stress accumulation through the life course. These factors include, but are not limited to, the very same factors which make Black mothers more vulnerable to autoimmune disease. And this section is also highlights the cyclic nature of in utero programming, wherein an individual's mother had elevated stress accumulation, which genetically predisposed them to autoimmune disease risk. The impact of sex-specific differences is also a factor contributing to the cycle here, as women suffer the highest rates of autoimmune disease incidence. Together, we see the weathering hypothesis in action. Sociodemographic factors and genetic predisposition increase maternal stress accumulation, which leads to in utero programming of autoimmune disease and contributes to the transgenerational cycle. So these are the primary objectives, as I stated previously. And in terms of methods, this scoping review is performed using PubMed as a database. The initial step in searching for relevant articles was identifying three concepts which would be broad enough to capture the target articles, and we would narrow this after our search afterward with our exclusion criteria. So concept one includes terms like stress and allostatic load to capture studies including variables surrounding stress. Concept two used an inclusive pregnancy and infant search to capture our target population. And concept three included autoimmune disease as a mesh term and various autoimmune diseases, which specifically have higher incidence in Black women and display racial health disparities. Article strength, strength of evidence, quality, and risk of bias analysis were also performed using validated global criteria and standards. So this figure shows a modified PRISMA flow diagram of the review's methodology. As stated, PubMed was the database of choice, and while the search concepts were completed together, this shows the breakdown of the number of studies returned per concept. Notably, the studies were excluded if they were older than 10 years, did not have outcomes related to in utero autoimmune disease programming, and discretion was used on the inclusion of criteria of studies using animal models and overall best fit. Ultimately, the primary search of concept one returned 73,971 studies, and I narrowed this to 10 final studies for analysis in the review. As as results, outcomes were summarized into 5 categories with their associated strength of evidence. The first result had a moderate strength of evidence, was that maternal stress is associated with HPA axis alterations, which affect the immune system development of the fetus toward pro-inflammatory profiles and increase the risk of developing autoimmune disease. The analysis also showed with moderate strength that elevated testosterone levels in males as compared to females is associated with better outcomes in males with autoimmune disease. This indicates a risk of developing autoimmune disease may be involved in germline mutations resulting from paternal stress exposures. Regarding inflammation and infections, moderate evidence showed maternal infections may induce cross-reactivity and initiate autoimmunity in fetus and in utero. Maternal inflammation induces T cell and toll-like receptor dysregulation toward pro-inflammatory activity in utero. Moderate evidence was also shown to associate maternal psychological stress with high levels of corticosteroids and estrogen, and fetal exposure was associated with development of autoimmune disease later in life. And lastly, the risk of developing an autoimmune disease is greater in populations of lower socioeconomic status individuals, although this evidence had a low strength of evidence. So overall, the key findings of this review suggest that Black women are more susceptible to pass on increased autoimmune disease risk due to their increased susceptibility to viral infections, which induce cross-reactivity reactions to self. Also, maternal inflammation induces T cell and toll-like receptor dysregulation toward pro-inflammatory activity in utero, and is likely a contributor to high rates of inflammation and increased risk of autoimmune disease in fertile and Blacks. Finally, maternal stress is associated with hypothalamic pituitary adrenal axis alterations, which affect immune system development of the fetus toward pro-inflammatory profiles and increase the risk of developing an autoimmune disease later in life. So the major strengths of this review are a comprehensive synthesis of fields to focus on filling a crucial research gap, the highlighting of the importance of stress management in vulnerable populations, and the analysis of quality, bias, risk, and strength of evidence. While limitations are the lack of direct evidence that is applicable specifically to the target population and the use of only one database, which may have limited the ability to capture all existing evidence. The implications from this scoping review are that weathering hypothesis provides a salient perspective wherein Black mothers' experiences navigating social, political, and economic disadvantages contribute to their accumulation of stress over their life course. And this accumulation of stress is not only responsible for reduced health outcomes for the mothers, but is also associated with the increased likelihood of initiating autoimmune disease risk in offspring. The theorized mechanisms of action of in utero autoimmune disease programming proposed in this review are HPA axis dysregulation, toll-like receptor dysregulation, and cross-reactivity after exposure to maternal infection, and genetic variations due to hormonal and microbiome shifts. While the scoping review illustrated various proposed mechanisms of in utero programming of autoimmune disease, it clearly highlights the lack of existing research. Future research that would specifically fill existing gaps should be longitudinal in nature and validate racial differences in chronic stress exposures and transgenerational autoimmune disease programming. So I just wanted to acknowledge my great uncle who sparked my interest in this field initially, my advisor and first reader, Susan Gross, and my family, my partner, my dogs, and of course, my professors here. And that's the end of my presentation. I'm happy to take questions.
Kristen, do you see any?
Not yet. Yeah, not yet.
All right.
Good.
Yeah, Cynthia has a question.
Sure.
Great job, Gabrielle. It's just very humbling to look at your Prisma diagram and to see you started off with over 170,000 articles, if I read correctly, and got down to the 10. So kudos to you. I'm suspecting that your dogs were not particularly helpful, aside from the moral support in that process. But my question for you is, it's really interesting to think about the accumulating body of evidence that we have that, whether it's sort of structural determinants in communities or, the things that you highlighted as being contributing factors that influence sort of outcomes at a population level for really important groups within our population. Any thoughts about in public health, how we need to be translating that compelling sort of biological link to actually move people's minds and hearts to adopt policies and programs that address sort of the root causes?
That is a fantastic question, and one that I think about quite often. I think with regard to, taking this research and taking this information and making some level of action, I think, as a researcher, my first instinct is to say we need more data. We need to better understand the problems at hand. But I think that even, with these research gaps, I think the biggest thing is to, begin taking some level of action. So I think obviously addressing social, economic, and political disparities is the first step, right? I think if those are contributing in a large way to this accumulation of stress, that's one way that we can approach it. I think that overall, looking at stress as a disease in many ways, or a contributor to disease, is another thing that we don't, necessarily address. And so, just addressing mental health as a whole, but then looking at communities where we have women who meet this exact criteria, who live in high density areas, who experience more viral infections and things of that nature. Addressing those communities specifically, I think, will help reduce the inequities.
Okay, so our next presenter is Jordyn Britton. She came to us with a BS in biology, and the title of her presentation is The Multi-Level Predictors of Adherence to Nutritional Supplementations During Pregnancy in Low and Middle Income Countries. Jordyn?
Thanks for the introduction. I'm just gonna share my screen and let me know when you can see it.
Yep.
Okay, perfect. Okay, so thank you everyone for being here. Today I'll be presenting my paper on the multi-level predictors of adherence to nutritional supplementation during pregnancy in low and middle income countries. I don't know why it's not changing. I'm sorry. There we go. So this paper will answer a primary research question, and that is what factors are impacting adherence to nutritional supplementation during pregnancy, and are these factors present at multiple levels? And adherence is going to be defined as the extent to which a patient's behavior matches the agreed recommendations from a healthcare provider. And at some points, you may hear me talk about compliance. And in this case, every paper that I included in this paper was going to use that same definition of adherence. So even if I'm saying compliance, in this case, it's going to be interchangeable. And so now I'm going to briefly go into the prevalence of malnutrition in low and middle income countries. Malnutrition is defined as an inadequate consumption of vitamins and minerals in the diet. And micronutrient deficiencies affect about 2 billion people worldwide, but women and children in low and middle income countries are most impacted. So during pregnancy, deficiencies actually worsen due to increased energy and nutrients that pregnant people need to consume to support their pregnancy. And nutritional deficiency is most prevalent in these 3 regions, with the highest burden in Sub-Saharan Africa, South Central Asia, and Southeast Asia. And so micronutrient supplementation during pregnancy effectively reduces maternal malnutrition, but there are many factors in low and middle income countries that prevent women from taking their nutritional supplementation dosage, which are considered the predictors of adherence. And so now we'll go through the multi-level predictors of adherence, starting with interpersonal factors, which are any barrier that occurs within oneself. Then we go to interpersonal factors, and those are ones that are operating between 2 or more people. Community and environmental factors involve one's physical surroundings and the resources available in the surrounding area. And finally, government and political factors include any policies or government factors that impact one's ability to receive or consume nutritional supplementation. And so now we're going to go a little bit into the specific predictors of adherence, starting with intrapersonal factors. And that is education, forgetfulness, and side effects. Forgetfulness just meaning that many women just simply forget to take their supplements. And so there are a lot of interventions that were created to help with that. And then we look at side effects. And in this specific case, we're looking at the side effects that women actually experience. A little bit later in the community or environmental level, you'll see me talk a little bit about social norms. norms. And there is a social norm that many women actually don't adhere to supplementation because of the fact that they believe they're going to get side effects, even if they haven't actually experienced them. And so that would be more related to a social norm. And then finally, education. And so we're going to go through a specific example from a study that was done in Indonesia. And in that study, pregnant women were about 18.7% compliant if they had 0 to 5 years of schooling. And then if pregnant women had 6 to 8 years of schooling, their adherence increased to 27.2%. And then women with more than 12 years of education had about 39.1% adherence. And so with that, we kind of get a better understanding of how education in turn impacts adherence. And there are a number of reasons why this could be, but I do believe that it could have been due to increased education, meaning that women are potentially more aware of their health status or more understanding of supplementation or the benefits of supplementation, or just a couple of reasons why. And then we'll go into interpersonal factors, and this is primarily related to support, family support, social support, and professional support. And so social support, meaning like if a woman is potentially going to a pregnant woman class and she's working with other women that she's not related to, that would be considered social support. Professional support, meaning that maybe a community health worker is helping her through this process, or maybe her physician. And then finally, family support. We'll go through another example from a different study, also based out of Indonesia. And so family support was actually positively associated with adherence to iron folic acid supplementation. And so women who received no family support were adhering at about 16%. And then women that received some family support were adhering at about 27%. And then women that had full family support, which is considered a pregnant person having a supportive partner who attended all the prenatal visits and discussed all delivery plans with that person, they were adhering at about 40%. And so this just really helps us get a better understanding of how family support is further impacting adherence to supplementation. So now we'll go through the community and environmental factors, starting with proximity to healthcare facilities, urban versus rural areas, availability of supplements, socioeconomic status, and then finally social norms. And then for the sake of time, we'll really primarily focus on social norms, and an example from the Rani project that was based out of India, which looked at social norm-based interventions' impact on increasing adherence to supplementation. And so women in these villages actually refrained from supplement intake for fear of producing a larger baby and a surgical delivery compared to a vaginal delivery. And so this is an example of how a social norm, they believing that if they take their supplements, they're not going to be able to have a vaginal delivery, is not something that's necessarily true, but it's something that the community believes. And so it's actually preventing women from taking their supplements. And so finally, we'll look at the government and political factors, and that's cost, national stockouts, and procurement of supplements. And we'll really focus on this study that was done in Senegal. And so this study in Senegal looked at national stockouts, which is really related to supply at the national level. And so women actually purchased supplements in Senegal from unreliable sources because there was a national stockout in the country. And so when women were forced to buy cheaper supplements, they're more likely to experience these side effects that were decreasing their adherence. And so as a result of that, national stockouts was leading to side effects at the intrapersonal level, but then it also further led to this community norm of side effects being a result of adherence. So women were refraining from taking supplements, even if they hadn't experienced them, because of the amount of women that had to take low quality supplements. And so this was one of the first examples where we see how the multi-level predictors are not independent. And so when you look at this diagram here, you see that we have intrapersonal, interpersonal, community, and environmental factors all leading, and government and political, all leading to adherence. But we can really see here that they're all related to one another. And so based on the findings of this paper, it's really, really important that we acknowledge that that these factors are not independent, but are actually all related to each other to impact adherence. And so in order to effectively improve adherence to nutritional supplementation, it is necessary for future research to explore the relationship between factors at different levels. And so currently nutrition research has not yet analyzed the relationship between these factors. And so it's crucial that we create a more comprehensive and holistic view of the predictors of adherence and their relationships in order to create an intervention that maximizes its impact. And so because of that, I created an intervention that hopefully targets a couple of different predictors of adherence. And so we're going to focus on a supply aspect of the intervention as well as the demand side of the intervention, starting with basically, my intervention strategy proposed that community health workers would lead monthly training sessions that distribute free supplements, provide informational education packets, lead an education-based discussion on the importance of supplements during pregnancy, and monitor blister packs to ensure that women are actually consuming their supplements. And then during these sessions, women would have the opportunity to share possible reasons for not complying with their recommended supplement dosage, which in turn would help with social norms. And so at the supply side, we see distribution of free supplements really will help with cost. It will help with support by having community health workers distributing this. It provides professional support, and then it also helps with procurement of supplements. And then at the demand side, we see education will help at the intrapersonal level, and consumption monitoring will also help at that interpersonal level. And so in conclusion, maternal malnutrition can lead to long-term effects into adolescence and adulthood. And there are factors at multiple levels that impact adherence to supplementation. These factors are not independent. And so it is necessary that we have a comprehensive and holistic view of the predictors of adherence and the relationship in order to create interventions that significantly improve adherence to supplementation. And so I want to thank you all for listening. I briefly want to acknowledge Dr. Rajiv Ramal, my primary reader, as well as the Crown team that's here today. Thank you guys so much. That's where I completed my field placement alongside the Threads Research Lab. It's another place that I worked on my field placement. I want to thank Dr. Mary Catherine Augustin, my advisor, Kristen McCormick, my academic program manager, and finally, my family, friends, and the PopFam cohort. Thank you guys so much, and I'm open to answering any questions that you may have. Thank you.
Thank you, Jordyn.
Thank you.
In your presentation, you talked about family, professional, and social support. Why do you think that support is such a major predictor at the interpersonal level?
Yeah, that's a great question. I think that support really just helps with accountability. So when there's someone that's available to help you remember to take your supplements, whether that's a partner or a family member, or I saw an example with a study that was done actually in Bangladesh. And so there was a percentage of, in Bangladesh, there are a lot of women within 15 to 19, about 28% of women in that age range are childbearing. And so because of that, we actually saw that mothers and mothers-in-laws were actually ones that were actually reminding young girls to take their supplements. And so social support is really, really important, just support in general, because it really just helps with accountability. And as we saw at the intrapersonal level, there was that predictor of forgetfulness. And so when you have someone that's reminding you, you can kind of always remember that you kind of need to take this supplement.
Okay, great, thank you. And the next question, you mentioned urban versus rural areas is a predictor of adherence. Are urban and rural areas more likely to adhere to supplements?
Yeah, great question, Tira. So basically with urban and rural areas, it's actually, the research was not conclusive. So that's why I included both of them. So we saw that urban and rural areas in different regions were actually more likely to adhere to their medications and so to their supplements. And so we basically can see now that we actually have to look at the relationship. It may not just be urban or rural areas, but we need to also acknowledge what other factors. Is it proximity to a healthcare facility? Is it the supply? Is it national stockouts? What is actually helping with improving adherence? And so it's not just one factor. And so that's why I mentioned it as a predictor of adherence, but we also need to acknowledge the relationship between them. And so that's why it was really upsetting that I couldn't find a actual set direction of where to go with this, but it showed that these predictors are not independent and that they have a lot of relationships with each other.
Okay, great. And then another question from Stacy. She's asking, you mentioned the importance of social norms. Do you have any suggestions for future interventions to address changes in social norms to support improved supplement adherence in this population?
Yeah, so for me, I think that it really has a lot to do with having maybe training sessions or certain things that women can go to within their community with a community health worker or someone that understands nutrition, kind of being able to have lead these conversations. And so when women are speaking and talking about their experiences with supplementation, the idea of certain things such as, oh, if I take a supplement, I'm going to have a larger baby and then I'm going to not be able to have a vaginal delivery. All of these things can actually be curbed in a conversation with a community health worker. And so that's why I think that it's really important that when we're distributing supplements, we have women that are from the community distributing them and also working with those women to further help with determining, like, okay, what are things that this community believes and how can we spread knowledge and education on why this is maybe not the case, or why maybe someone may have experienced this and other women have not. And so I think that it's really important that we just kind of have community-led conversations where women don't have to go to an antenatal care visit to get those answers.
Great. And we have one last question from Susan Gross. She stated recent studies have shown that women who are not nutrient deficient, supplementation is not effective and might be harmful, especially microbenign overgrowth with iron. How would you target supplementation so that this does not happen?
Yeah, so that's a great point, Susan. So I think that it really has a lot to do with actually also ensuring that women are going to antenatal care visits. I think that we can really help in the community and we can supply supplements, but it's also important that we're screening and that we're ensuring that women are actually nutrient deficient. And so that is all about really just improving accessibility to their services, whether that's bringing community health workers in the community to be able to do this testing or bringing women there to their antenatal care visits. But I think that all is related to really just improving people getting tested and ensuring that they're actually nutrient deficient. And also it's important because there's a lot of different relationships. So if people are taking one supplement and they think that they're nutrient deficient in a bunch of different micronutrients, that can lead to a lot of different side effects related when you're taking a bunch of different supplements at the same time. And I think that that's really important, that you're really going to someone in your community or and asking, how can I actually make sure that I'm going to my antenatal care services, and just increasing accessibility to those as well as also acknowledging the cost of those visits. Because for some countries, this cost is a barrier as to why women do not go. And so it's a matter of, should we bring these things to the community and make sure that it's more accessible and more affordable for women to be able to use.
Great.
Thank you so much.
Great. Nice job. Nice job.
Thank you.
Okay, so last but not least is Jovial Karenzi. She came to us from Dickinson College with a BA in sociology, and her presentation, it's a long one, so let me just say it. Factors and barriers informing male engagement in fertility and family planning decisions in Sub-Saharan Africa, a systematic literature review. So Jovial, you're on.
So hi everyone, my name is Jovial, and today I'll be presenting on the factors and barriers informing male engagement in fertility and family planning decisions in Sub-Saharan Africa. To start, I'll take you through a background. So despite recent progress in contraceptive uptake, there's still high rates of unintended pregnancies and unmet need for family planning, particularly in Sub-Saharan Africa, where 9.1% of women experience an unintended pregnancy each year, and 23.7% of women have unmet need for family planning. So as a result of this, the unmet need contributes to high maternal mortality, which accounts for nearly 70% of the estimated global maternal deaths. So although there's been decades of investment in family planning programs in Sub-Saharan Africa, the demand side exceeds the supply side of unmet need. And a review of demand generation interventions show promise in increasing contraceptive use. However, there are still barriers, as half of women at risk of unintended pregnancies do not use family planning out of fear of side effects, concern for their future fertility, as well as a lack of social support, including from their partners. So moving on to male engagement in family planning. First, I'll define this. It is the involvement of men and boys in family planning programs across life stages, including addressing gender norms and gender equality. And so the goal here is for men to be supportive partners, advocates, and users of contraception. So in understanding the realities of unequal gender power dynamics in many sub-Saharan societies, there's an increasing recognition that male engagement should also be considered, as men are the primary decision makers in the household and have a crucial role on family planning and fertility decisions. Couple-based communication programs and interventions have proven to be promising approaches to increasing family planning use, and male engagement is a growing strategy in sub-Saharan Africa to enlist men as advocates for women's access to and use of family planning. And so while much of the momentum for male engagement is growing, there's still a gap in the understanding of determinants of male engagement, which leads me into my research question for this study. Based on literature, what factors and barriers inform male involvement in family planning decisions in sub-Saharan Africa? To start, I'll be taking you through my methodology. So after defining a topic of focus, I identified my inclusion and exclusion criteria, where I selected peer-reviewed articles published between 2018 to 2023, published in English with Sub-Saharan Africa as the setting. And once I identified these, I moved on to conducting my literature search, for which I used Google Scholar, PubMed, and Scopus, with key terms including family planning, fertility decision, contraceptive behavior, male, man, husband, or partner, engagement, participation, or involvement, as well as Sub-Saharan Africa. I then went on to my screening process, and if you follow the chart to the right, you'll see that search results as of April 2023 yielded 162 articles, and through screening and excluding articles based on dates and titles, abstracts, and finally the full text review, I decided on the final 31 articles. And after selecting these studies that were relevant to my research question, I summarized the evidence in a narrative synthesis, and I will discuss findings from that in the next slide. And so I identified 4 major themes in my findings. The first one being large families to gain social status. Generally, there's some parts of Sub-Saharan Africa where men have more pronatal views than women, as they're socially rewarded for having larger families. And so societal beliefs around childbearing influence male partners' desires for additional children, and therefore their involvement or lack thereof in family planning. Next is the affirmation of male authority. Family planning is perceived as a threat to male authority, as men are expected to have control over women and head household decisions, including those on childbearing and healthcare. Studies show that some men are more closed off to family planning due to fear that their female partners would abandon childbearing responsibilities, gain attention from other men, and that contraceptive use would promote infidelity. Now, on the flip side, communication and gender equality were identified as facilitators of male engagement, as they ensure that both male and female partners are empowered to discuss their shared goals surrounding pregnancy, and male partners being involved in family decisions are more likely to support their partners with access to reproductive health services. And moving on to knowledge, a substantive lack of knowledge around reproductive health matters has led to misconceptions that have shaped male partners' decisions, including misconceptions about side effects, which hinder male engagement due to the need to protect their female partners against perceived harms of contraception. Additionally, concern over their own virility is a barrier, as some male partners feel as though supporting family planning is a threat to their masculinity, therefore creating feelings of shame and leading to disapproval of family planning. On the other hand, increased awareness of family planning favored men's involvement in contraceptive uptake. In some studies, participants highlighted their awareness of benefits of using family planning, including preventing unplanned pregnancies and STIs, better child spacing, spousal health, as well as the economic and physical advantages associated with family planning use. Moving on to my final finding, there's factors and barriers that reflect across multiple levels of males' socio-ecological environments, starting with peer reinforcement at the relationship level. We saw that peers reinforce entrenched gender norms and exclude men who don't adapt to traditional gender roles. And some studies highlighted that that male partners did not discuss family planning with their social environments due to the topic being perceived as too sensitive or private or showing weakness on their part. As for the religious and community reinforcement at the community level, male partners are more receptive to messages that come from influential figures within their communities and often base their beliefs and practices on these messages. And on the other hand, results show that men who were exposed to religious leaders that spoke in favor of family planning were more likely to engage in it due to trust in their leaders. Lastly is the healthcare system reinforcement at the societal level, where results showed that the lack of positive male involvement in family planning was reinforced by healthcare institutions that provide little to no family planning and SRH services for men. So there's this common misconception that sexual and reproductive health and family planning is strictly a woman's domain. And what this shows us is that the feminization of family planning services and education largely contributes to men's ignorance and lack of interest in reproductive health matters. And finally, limited SRH education for boys, along with limited services addressing men's needs and limited couple counseling are all barriers to male involvement in fertility and family planning decisions. And so what we can learn from this is that incorporating the value of male engagement in education and services is important in facilitating their involvement in SRH services. So moving on to the discussion and conclusion. So overall, the implications of the findings suggest that male engagement is necessary to advance and improve reproductive health outcomes. However, there's still little research on the determinants of their engagement, along with several other system level barriers. Also, male partners should be included in gender transformative discussions to challenge traditional gender norms and power dynamics that counter equality in family planning and fertility decision, counter inequality. It is also important to note that it is a multi-tiered responsibility, as we've identified the importance of reinforcement at different levels that empower men to step into their roles as partners. And so some limitations to this study include the language. Articles were limited to those only published in English, which may not be representative of the total body of literature on this topic. Also, there were limited qualitative research studies, which may have not reflected all the experiences and perspectives that influence male involvement in family planning and fertility decisions. Also, some studies samples were very small, so the findings from these may not be generalizable to a country or regional level. Another limitation was the inadequate research, specifically on male perspectives and incentive to engage. I also observed that many articles focused on specific countries more than others, which limits the generalizability and opportunities to note important differences in perspectives from other countries. And so finally, some recommendations for future research. We need more studies highlighting male partners' perspectives. There's also a need for additional research on male incentives to engage in family planning and fertility decisions. And finally, more studies should be conducted in different countries for a better understanding of factors and barriers of male engagement across these different settings. To conclude my presentation, I just want to say a few thank yous to Dr. Moreau, my reader, who's helped me from the beginning with my paper development to now. Also to my academic advisor, Mary Catherine, for being present all throughout, to Claire for helping me with my search strategy development. Thank you to Kristen for babysitting us and for being great with the whole coordination, to the entire PFR department, and last but not least, to my friends and family, some of who are present on this call. Thank you.
Thank you for noticing that many of the studies don't include data from men themselves. So I was just wondering if you remembered the split, and you can get back to me if you don't, on how many of the studies actually included data from men versus women only.
I would have to get back to you on the exact split, but I know that was actually one of the struggles with even like defining my topic, was a lot of these articles talk or are presented from the women's perspective. I would say maybe like a rough guess would be like 70-30.
Yeah, okay. Yeah, that's what I expected, but thank you. Really great work.
Thank you.
All right, well, congratulations to the 5 of you. You did a great job, a really impressive heterogeneity of presentations, and I think you made our department proud.